Welcome to Medical Monday.
Medical Monday.
Medical Monday.
Medical Monday.
Welcome to Medical Monday.
Yeah, it's Club National Underground Thunder bounce when I stop the ground like a million elephants. You can't stop a train.
Oh, hey everybody. Welcome to Medical Monday. So what this is a quick 5 or 10 minute video about something we think you should know about. Could be a protocol, could be a guideline, could be a cool clinical case. Whatever the case is, it's something we want you to know about. Could be something you want to know about, so make sure to make some suggestions. Today we're going to talk about the SCT guidelines. Let's get started. Alright, so here it is. This is the memo that went out March 27th. And so the reason we need to know this stuff is not necessarily to designate a call as an SCT, but you might get to a call or get to a transfer. Something's changed, or they're starting a drug that might fit this SCT level, and so you need to know what they are. Here's Dr. Richmond.
So it's been a while since we had the opportunity to revise the policy for specialty care transports, and we felt this was a good moment to help clear up any lingering confusion that may be out there. But often these cases are things that we're not used to seeing. It's not just a critically ill patient, but it's a very complicated critically ill patient.
All right, so real quick, let's get into it. What is an SCT? There's a definition from TDH, and I think the real important part of this definition is the patient requires specialized interventions, monitoring, and or staffing. So that's what designates it, and we want to know what those things are. So for it to be an SCT, could be vasopressors that aren't covered in your protocol, or more than one. It could be vasoactive agents, beta blockers, milrinone. It could be antiarrhythmics that aren't in your protocol. Could be fibrinolytics. We see these a lot in STEMI and stroke patients. Could be tocolytics, things that sort of slow down pregnancy problems, pregnancy-related issues. Could be paralytics, self-explanatory, insulin, blood or blood products, the procedures, mechanical ventilation, so if they're on a vent, any sort of invasive line monitoring. They can have an invasive line, but if you're monitoring, so arterial pressures, you need a transducer, you need specialized equipment. Our ALS trucks don't have that, so that's why we can't monitor invasive lines. Chest tubes, balloon pumps, external cardiac support, VADs, Impellas, transvenous pacemakers, things like that.
So the idea is to have those kinds of cases handled by CCPs who really, that's what they're trained and experienced in.
So for the advanced paramedics, this is what you can transport on your own. You can transport people on vasopressors as long as they're vasopressors that are in your protocol that you're familiar with and at your protocol dose. If they're outside your protocol dose, then that would designate it as an SCT. Maintenance fluids are okay as long as they don't have riders, electrolytes, calcium, or potassium. Narcotics and opiates are fine. Mag sulfate for asthma, not for pregnancy issues. And there are some infusions that are not covered in the advanced scope. TPN is fine for an advanced paramedic to run. Antibiotics, some anti-epileptics, heparin is okay to run as an advanced. If it's not specifically excluded in the SCT criteria, then for the most part, you're able to run those. There are a few exceptions which are outlined in the directive. Ventilators in a non-emergent setting where someone that operates that vent is accompanying the patient. So we see these a lot with people on home vents, and either their family member or an RN or somebody there that operates the vent is going with the patient. That's fine to run with an advanced. Home medications where they operate a personal infusion pump, or people that have a ventricular assist device that are complaining of something not related to that device. So someone with a VAD that stubs their toe, that's obviously fine with an advanced provider.
You have any questions about things, whether meds or monitors, procedures, other devices that you think maybe we can handle otherwise? This is not set in stone forever. This is first try at clearing up a little bit of the confusion, but we can continue to evolve this as we go. Anytime there's a question or there's maybe a conflict over whether a facility may say this patient really needs to go, and your sense, or more than your sense, that this is in the directive that it should be CCP, you are please always welcome to give us a call on the OLPG line. You certainly can call your 80 supervisor and certainly have dispatch get in touch with any CCP who's out there, and any or all of us will be glad to provide you some guidance.
All right, everybody, that's it for this week. Thanks for watching. Hope you have a wonderful week, and we'll see you next time. See ya.
I'm so sick of you.